Carrie, I just sent you a request to be a contributor so you can take yourself, I think it'll allow you to take yourself on and off mute so you can participate in the meeting. Carrie and Kathy, I sent you both. There we go. To make you contributors. Good, you saw it. Hi, Gio. I think you're still on mute.
Hi, Lynette. Hi, Mary, and everybody else. I noticed we're already recording, Lynette, so good looking out on that. Just want to make sure. Yes.
Good afternoon. We're going to give everyone a few more minutes to come in. Thank you, everyone that's already here. This meeting is being recorded, and we have more people coming in, and we'll get started in just a second. Thanks, Josh. Okay. We have quorum. So excited. Okay, we will start. It is 12:01. Welcome to the Mental Health Parity Advisory Committee meeting that we've been trying to have, and we have finally made it. We've gotten aside from all the technical issues with WebEx, so I apologize. Hopefully this will be a better platform for us to use. So far, so good. Can everyone hear me and see me? Awesome. Let me do roll call. Ananda Smith.
I'm here. Hello.
Hi, welcome. Derek Wertheim. Dr. Fowles. You're on mute, but I heard you say, I saw your mouth say present.
Sorry about that. Yeah, I'm here and good to see y'all.
Carrie Steving.
Here. Can you hear me?
Yes, I can.
Yeah.
Oh, good. Thank you.
Kathy Busby.
Yes, I'm here, but also I just had a text from Monica that said the link that she got was only for audience.
Yes, I'm going to send her.
Okay.
See her pop in. Monica Curry.
I'm now here. Hooray. Thank you, Kathy. Appreciate the assist.
Nicole Porter.
I'm here. Thank you.
Hi, Vista Thompson.
I'm here. I'm going to be off camera for a little bit because I'm trying to finish my lunch, but I'm here.
Okay, no problem. And Bonicia Hill. Okay. Well, again, and before I go, I want to make for the record, Derek Wertheim just joined. Let's see if we can get him talking to us. There he is. Hi, Derek. Still on mute. There he is. So we have Derek present. So the next part of the agenda, let me share my screen. So we have the agenda up. Everybody see the agenda?
Mm-hmm.
Yeah.
Yes.
Perfect. We have done an introduction. Did roll call, but I want to introduce our two newest members, Ananda Smith and Derek Wertheim. I don't know if either one, well, yes, you will. Ananda, can you kind of introduce yourself, what you do? She's representing the family member slot for the committee. But Ananda, if you could just give a little hello and who you are.
Absolutely. Thank you, Lynette. I am a native of Phoenix, Arizona. Been here my whole life. My mom's a native as well. So this has been my home forever. I've been in the pain management, addiction treatment space work-wise for the past 15 years, working in toxicology and lab services. Recently become a board member of the Michael Joseph Lasseter Foundation, whose passion and goal is to educate, provide services, resources, kind of bridge the gap for patients needing mental health services, addiction treatment, et cetera. So very happy to be here. Thank you so much, Dr. Hennigan, for including me, and looking forward to this meeting.
Thank you so much. Welcome. And Derek, could you introduce yourself? Derek is representing our inpatient facility slot on the board. Go ahead, Derek.
So thank you. So my name is Derek. I'm one of the lead supervisor patient care managers over here at Aurora Tempe. I'm a licensed associate counselor, been in the SMI world in some shape, way, or form since 2008. Yeah. So thank you.
Thank you, Derek, and welcome. Excited to have both of you, and we still have a vacancy for industry person on the board. So anyone knows any interest, send their information my way or have them send me their resume, and we can fill these last few slots for the board. Very exciting. Moving on, there isn't a media update right now. Things are we had a robust month of mental health awareness month. Tyler, one of our IT and public communications individuals here at the department did an amazing job with slides. And we are gearing up for Suicide Prevention Awareness Month next month. So be looking out for all of our social media stuff on our Instagram, Facebook, and YouTube. And so we are present on, they do a great job with our social media. So I want to give kudos to them, even though they're not on, want to know that they do an excellent job. So next, Josh, if you are ready, I can turn it over to you to present for updates on things from ADHS in your department.
All right. Is it okay if I steal control?
Yes, let me start sharing.
Okay. Perfect. Outstanding. So hopefully everybody can see that. Sorry, again, I'm having some bandwidth issues today at the house, so I'll be off camera for this. But my name is Joshua Stegemeyer, and I'm with the Department of Health Services, where I'm the Suicide Prevention Program Manager. So got a few updates for you today as we get into this. I see that there's an update for the crisis system right after me, so I'm not going to steal anybody's thunder. I hope we'll do a real short one there. Short thing on the suicide prevention plan refresh activities, but the main thing that I wanted to talk about today was some of the initial findings from our veteran verification project. That's an outgrowth of our suicide mortality review program, and I'll talk about that when we get there. But that's the main focus of our updates today. So. Getting started, we'll see here, as usual, I just present the 30-day rolling average of the two main crisis lines here. The state line by volume is our largest, and that's this first slide here. You can see the circled number there is the number of calls that come in. We've got our answer rate and our statewide stabilization rate. Also, in more the bottom left there, you'll see the reasons for calling. As usual, I like to point out that suicide is not the number one, right? And that's probably a good thing if we're seeing people call into the crisis lines preemptively and more proactively, right? Before things are getting to that issue level. So we really have social concerns here being number one, but number two is self-harm and suicidal. Number three, coordination of care. And number four, anxiety. So some of those numbers there, these slides will go out afterwards. So if you want to take a look, this is also a publicly available dashboard, so you can follow it along. Moving to the 988 line, though, a few different things I wanted to talk about here. Mainly the call volume here. So when I first did the poll for the statewide thing, I noticed the numbers were a little bit down, but I didn't realize that they were about 3,200 calls down over the past 90 days. Well, when I looked at the 988 numbers, I definitely noticed that they were over 10,000 and that they'd risen from around 9,000 when I did the last poll in June. Right. So comparing the two, basically we've lost, I think, about 3,288 calls on the average from the statewide crisis line, and they'll show up in 988. So just an interesting thing there, losing a few calls from the state line, and they're showing up on 988. But you'll see that here, even a larger section of the calls are for social concerns and self-harm. With anxiety being number three here and substance abuse being number four. So same numbers, 1 and 2 when you compare it to the state line, but slightly different order for 3 and 4. Little bit different data you can see here, but the other thing I wanted to point out is just kudos to Solari, because when I compared these, the stabilization rate is up and the answer rate is up compared to about 90 days ago when they'd actually been getting fewer calls. So busier they're getting, the better they're getting. So I just wanted to highlight that. It's a great thing for our contractor to be getting better like that. So Next thing then, moving on to the state plan refresh. We are taking our 3-year state plan, the 2024 to 2026 plan, and we're making it a 5-year plan starting in January. And in order to do that, we're taking our time and slow walking it through the right process. So in May, we had the kickoff to that event. We had some folks show up for that. And then we collected the input, turn that into a hybrid in-person event with some virtual attendees there at Rio Salado College in Maricopa County. And then we bought the took all that together, put it into a very prototype draft, and got more feedback in July and August. And right now I'm sitting on our draft that is just about to be our first draft that I can start sharing out. So unfortunately, it's not complete yet. Otherwise, I put a link to it. But right now, it's almost complete. But as soon as it is, you can see the last step here is that we're going to be internally refining it, finalizing it for publication, and then be presenting it hopefully in its final form October 28th and 29th, I believe, is the dates for this year's HOPE conference, the annual suicide prevention conference in Arizona. So that'll be the hope, is to have the final version then, and we'll distribute it out statewide through the rest of the year. So that's the timeline on that state plan, and you can contact me if you'd like to be involved with the work groups, which are kind of the main platform for stakeholders to get involved with the state plan right now. Moving on, though, I just, in order to talk about the Veteran Verification Project, I have to talk first a little bit about our cooperative agreement to expand SMR. But before that, I have to introduce the Suicide Mortality Review Program, which is what SMR stands for. This will be the last time, really, that I think I'll be presenting on this. Internally, it moved to a different bureau, and so I'm no longer supervising it. But with that change, we have a culmination of some really big projects. All right, so the Suicide Mortality Review, just as context, is where we review cases of deaths by suicide from around Arizona for lessons learned at the population level and down at the local level, so that we can create prevention recommendations and use that data to hopefully prevent future loss of life to suicide. So last year, VA and SAMHSA got together and gave us some funding to expand that. And that's what this slide is describing here, is our cooperative agreement. Now, that's not a grant. Unlike a grant, cooperative agreement means the federal partners are way up in your operations, and you report to them, almost on a weekly basis. They're aware of everything you do and everything. So it's a real partnership as opposed to like an administrative monitoring situation. But that's where we find ourselves. And as part of that work, we did this thing we called the Veteran Verification Project, which was to take all the deaths by suicide and audit them to see if the military service block is accurate. So on the death certificate, there's a block that says military service is checked yes, or it's not checked, right? And so that's the indicator that someone served. We wanted to know how accurate that was. So we have some initial findings from this project. We weren't actually able to complete it. It's a huge undertaking to do this manual verification, and these record systems do not talk to each other. As a matter of fact, they're kind of made so that they don't talk to each other. So we have to bring different people all into the same room with the same, with access to their systems, and manually read off numbers to each other. But we did that for about 60% of the 1,597 death certificates in 2022. So in summary, we found some things that I want to talk about, but I put this mostly in the slideshow for other folks that'll be looking at this afterwards, because what this describes is that we found that our system's about 37% inaccurate. Right, so that means 37% of the time when you look at a death certificate and that says military service, it's not going to be correct. Right, either that person is marked as having served and they didn't serve, or they're marked as not having served and they did in fact serve. Interestingly, both of those populations almost cancel each other out. So we're only +5 on veterans identified, right? So what we really have is a big batch of people who shouldn't be in our demographics for veterans because they weren't, and a big batch of people that weren't counted because they weren't identified as being veterans. So this slide right here describes some of the patterns that happen when we introduce false data into a data set. Right? It inflates the denominator, making veteran suicide more common in certain demographics than it actually is. False patterns around age, race, ethnicity, geography, right? Basically, we're taking somebody's life story and building population data out of it. But if we're not getting accurate data in there, it's not going to reflect our population. And that's the bottom line that this slide explains. So here we have some challenges for Arizona related to what happens if our system is not accurate, right? We use this data to allocate funding, develop outreach materials, set priorities, right? And I mean, I think the wheels are spinning in our minds. What happens if we end up with non-veterans classified as veterans and vice versa? So again, you can review these slides more specifically when you get them in your mail. But I also want to focus in on some more challenges, though, about the delayed support for veteran families, right? They might not understand the benefits that they qualify for. They might not get their loved one the benefits that they qualified for, the burial and internment benefits, the grief counseling. There are a lot of different things that apply either way if people are in the wrong category. And impacts accountability and oversight, right? And all kinds of other things. It's just a cascading pile of dominoes when the data starts off wrong. Okay, and so that's what's described on this slide. But I did want to spend some of my limited amount of time on the actual findings, because there are 3 big ones that we identified from our analysis of the data. The data itself is a deliverable in our cooperative agreement. And once we've delivered it, I've been told we'll be making it public. So you will be able to take a look at the actual data here in probably October. But until then, we're just talking about the findings. But the first one is that female veterans are more likely to be misidentified by a rate of about 3 to 1, right? So if we look at what in the unverified data, females represented 2.6 of veteran deaths, 2.6% of veteran deaths. In the verified data, they represented 8.2%, right? Triple the number. And so that is a big thing, right? Especially, and there's a whole lot of reasons for why this happens. But I'll wrap that up here with these other ones because we start to see some themes. But expanding the points, you can see some things around why they are less likely to be counted. One, they're less likely to self-identify. Families are less likely to be aware. And we know this is a well-known, well-researched subject of systemic exclusion of female veterans, right? So this is more data that adds to that. Younger veterans are underrepresented. What we saw in this is that our younger vets, like let's say everybody from the Gulf War forward, is undercounted, and everybody from like let's say Vietnam and above is way overcounted. And the reasons for this are the requirements, I think, for getting VA benefits. If you served in Vietnam, everything was paper records, and everybody knows that. So at death, there's just less of a burden of proof when the family says that they're a veteran. Frequently, you don't have to provide a DD-214 or the actual records. The funeral director just takes the family's word that that was a veteran. Grandpa was 85, served in Korea. Well, what we found out is that a lot of those older veterans, for whatever reason, were just overcounted. And that this burden of proof for the younger vets, quite frequently when you die outside of your normal time span, die by suicide, for instance, 35, 40 years old, you don't have your life in order. You don't have your records and final affairs taken care of, and your family might not even know that you served or that you have stopped serving. They don't have the documentation. You didn't have it in your apartment. And so if you die by suicide, there's the burden of proof is simply too high. Right. And so that is what we're seeing, we think, when we look at the why the younger veterans are represented, just the a burden of proof. And this is talking about systemic preference, right? We give preference to the older veterans in terms of giving access to benefits. And the data shows that. And the final theme here is misidentification reflects disconnection and creates it. This is a way of saying that if the person didn't have a major relationship, i.e. they weren't married or in some kind of significant long-term partnership of whatever form, then they most likely, or they were more likely than not to be misidentified at death, right? And so we're really seeing that it's the importance of that spousal or that partner advocate that gets that veteran recognition at death. And if there is nobody in that status, it doesn't seem like other relatives are able to fill that void as well than the immediate partner. So you can see that being unmarried or separated, reflects fewer proactive or protective relationships and all kinds of different things there. But this is really important because this is one thing that connects the younger veteran community to the undercounted female veteran community, is that both of those groups, the younger veterans and the female veterans, are less likely to have significant relationships at the time of death, right? So these are three important findings that we took a look at. There we go. Sorry, that was a duplicate one from earlier. But those were three findings that we took away from our audit of the death certificates. And so that's really what I wanted to share with the group today, outside of the actual, sort of quantitative data updates, is sort of this qualitative examination of our death certificates. And we're getting closer to being able to release that. So now we're actually being able to talk about it. So with that, we can take some questions if we have time. Yeah.
We do have questions. Kathy, you want to go first?
Yeah, that was a very interesting, Josh. Thank you for that. Just a couple of probably more simple questions. Originally, you discussed about the 988 number versus the 211. Do those calls both go to the same answering? I mean, in other words, is Solari answering the 988 and 211, or where does the 988 go?
Okay. So this is a good time for me to talk about the crisis system in Arizona in general. And when I first started the position, I wanted to know, so I started counting. I stopped counting at 50. So we have more than 50 crisis and warm lines in the state. And so there are different contractors that run through them, but the vast majority are run through Solari Crisis and Human Services. So our statewide suicide and crisis line is run through Solari, and that's what this first slide depicts, is the metrics associated with that crisis line. But they also are the state contractor for 988. And report to the national contractor Vibrant. So that's the these are those metrics associated with that call line.
Okay, one other question was about you will no longer be reporting on this as it's been moved. Who has the oversight now on the veteran suicide mortality review?
The Veteran Suicide Mortality Review is an outgrowth of our state suicide mortality review. So it will stay around in its move to our Bureau of Assessment and Evaluation and our Office of Fatality Review. So previously, our suicide mortality review was housed in my office, which is our Office of Injury and Violence Prevention. But because we have 4 fatality reviews as a state, ADHS created an office for fatality review, and it's really been helping with standardization and stuff like that. So I'm sorry to kind of lose the direct program connection to the data source, but we're coworkers, so I'll still have a great deal of connectivity. But yeah, the supervision has changed over to our Bureau of Assessment and Evaluation.
Okay, thank you.
Vista, did you want to ask her a question?
Yes, on the reasons for calling, you said the number one was social concerns. What kind of issues get grouped under social concerns?
That might be if we have someone from Access's crisis team. I'm not sure if they'll be able to talk about that more specifically, but there are actually coded reasons for that, and there's a list of categories that fall under that. But some things might be relationships, interpersonal relationships, relationships with coworkers, parents. There's a lot of different types of relationships when you start breaking them down and coding them differently, just so that you can understand if people are maybe having parental issues versus child issues versus interpersonal relationship issues. It sort of reflects that whole spectrum of concerns.
Okay, and then my second question, thank you, was you said that the 988 line is getting calls that have been lost from the state line. There was a significant shift. Any explanation for that? Does it get better publicity or anything?
I don't know that the calls, have gone and been lost directly from the state line and gone directly to 988. So they're happening at the same time, but they may be unrelated. But I don't know why that is. I know that there has been some attention though around the program of 988, kind of in the national level news. Sort of, is it going to get funded? Is it not going to get funded? It was a health and human services debate, and kind of I saw it on Fox and CNN, so it was pretty nonpartisan issue whether to fund the crisis line or not. So a lot of free press, in other words. Maybe more people became aware of it. Just it's still relatively new, and I run into people every day who don't know that there's a 3-digit code for this thing anymore.
Thank you.
Any other questions for Josh? Okay, Josh, thank you. That was great information. And I will have to get in contact with your new counterpart for the suicide prevention updates.
Oh, I'll still be able to provide suicide prevention updates, just not the
Okay.
SMR ones. But yeah, we can definitely link up for that.
Okay, perfect. Thank you so much. Okay, moving along. Federal updates. I know that everyone has seen lots of stuff in the news, and a few months ago there was an executive order that the administration put out to pause enforcement on the 2024 final rule of MHPAC. And so it is under litigation at the moment. We don't know what's going to happen. We're at a pause. So that also impacts our rulemaking or updating on our end. We're kind of in limbo because we can't, and most states are taking that position. Geo just went to the NAIC conference recently. They didn't do a MHPAC working group there. I'm going in September. Where we're having a special MHPAC workshop working group where all this will be discussed. We'll see if any updates come out, if there's anything new. But right now we're just in limbo. And I saw Mary was on. I don't know, Mary, if you have any other updates or comments about our rulemaking.
Yeah, Dr. Hennigan. Our rulemaking is currently on hold until all this resolves. And even if it does resolve, then I think then there's also like an 18-month sort of cushion period after the final order from the court before enforcement will start. So our current rules are perfectly fine. They're enforceable. They don't need they haven't been changed since we enacted them. So we're just going to wait for the feds and to work through this litigation. The agencies were going to take a look at those final rules again to see how viable they were and see if there needed to be anything further on their part. So while they, have this little argument, we're just gonna sit back and wait. But our rules are fine. they're effective, and we're enforcing them as written right now.
So for those of you that are on from industry, this 2026, this coming up March, is a triennial report year. So you don't have to do anything different than the previous year. It's the same set of rules and guidelines that we did the first round. So if you have any specific questions about the reporting, you can email me. But as Mary said, nothing is changing on our end until we figure out what happens up at the top. So any questions on that? Or I don't know, Gio, if you have anything to add.
I don't, but I do appreciate that you brought up the triennial reporting that's going to be coming back full circle in just next year. So I think that, as Dr. Hennigan mentioned, for the insurers out there that have any questions, we're happy to talk through any questions on that. But I think that this next go around is going to be a little bit of a quicker process. And in great part, thanks to the collaboration that existed the first go around. So I'm very appreciative of that.
First round was a heavy lift, but for those of you in our industry, the process was great, and want to continue to be collaborative in how we did the approach the first time. So none of that will change. We'll stay the course and get ready for this next heavy lift coming up. Any questions on that at all? No? And as soon as we hear something federally, and we might all hear about it at the same time in the news, depending on how that goes. So I will keep everyone updated. And remember, on our website, we do have a news updated section. If you go to the Mental Health Parity website, there's a section about news and updates. So if something major happens, we'll get it posted there as well, so you can stay up to date. Okay, we don't have any need for executive session. Our next meeting will be in October, or let me pose the question. We can do the next meeting October the 6th, or we could do it November 13th, which I know we start getting into holiday time. If we do the October one, that would be the last one of the year, because we'll be in the last quarter. So I don't know if anyone has we want to decide that today and have it on the books. If you want to think about it and email me. I just know November gets a little rough too, because everyone starts winding down for the holidays. Any preference, October or November?
I vote for October personally.
Anyone else? Well, via email, if everyone has to look at calendars.
What was the exact date that you mentioned in October?
October the 6th.
Okay.
Or November 13th.
Okay. So a Monday. Okay.
Is that a Monday?
Yeah. Or November 13th.
I don't have a preference.
That's
Yeah,
6. No, not a Monday. I know Thursday is our day, so that's it.
That might be a holiday too. Oh, no.
So October the 9th. It would be either October the 9th or November the 13th. There we go. And like I said, I can send out a poll via email so everyone can vote and have time to look at their calendars and what's coming up. And we can take it from there. So, all right. Anything else for the good of the cause? So excited we got to have a meeting. Yay.
I don't have anything specific, but I just think it's interesting and probably important for this committee to keep monitoring. My call prior to this one was a continuing education program, and it was about all of the cuts to the federal agencies. And I think I had not heard the figure that at least 20% of the workforce at Department of Labor's, the ESB, the people that enforce, things like mental health parity, the workforce has been cut. And it'll just be interesting to monitor what the trickle down impacts are to, programs like we were just hearing about, cuts in workforce and, just all of the things that are flowing from the current administration in terms of resources devoted to, protection of mental health and all of those things. So
I agree. And that just, you saying that, this to just trigger this, I wanted to make sure I made mention of this today, just because we are a mental health community, we support the mental health community, and let's just keep our children right now. The tragedy at Maryville High School and just the stuff circling in the news, it's been a lot of kids that have lost lives over the past few weeks and months. We just want to make sure we're taking care of each other and our children as they've started going back to school, and keep our teachers and stuff in our thoughts and all administrators, so we can be ready to be, to serve our community from that capacity. So I just want to mention that. Like you said, and with the cuts, hopefully these kids are able to get services that need it. So
yeah, this call that I was on called out the cuts to the, I'm not going to get the initials right, but the LBGTQ. I'm sorry about that, but that line has been defunded.
Yes.
And, just the impacts to people are very, very concerning. So anyway, this is a good place to monitor that.
Our eyes on it for sure. Maybe we can add that as a agenda item next time, so we can go into the weeds a little bit with it and see if we can problem solve to try to help in some way to reroute those calls, whether it's a church or whatever. We can brainstorm about it. So I'll put that on the agenda for next meeting. Anything else? Right. Thank you, everybody. You can have back about an hour, about 45 minutes of your day. We will adjourn the meeting at 12:38 p.m. And this seems to be the best way to do this on Google Meet. So thank you. And I will see everybody next meeting.
Thank you.
Thank
Yeah.
you.
Thank
Have a
you.
good night.
Bye-bye.
Bye.